Hello and welcome to the American Society of Regional Anesthesia and Pain podcast, Azera Wrap. I'm your host, Raj Gupta, and we have a fantastic show for you today. Before we get into the show, I do want to make a few announcements. Let me pull up the screen here about some important stuff coming up with Azure Pain Medicine. So first things first, we have our annual meeting coming up. This is in the spring in Las Vegas. It's the annual meeting for regional anesthesia and acute pain medicine. The most important thing to know right now is that your abstracts are due January 6th. That's coming around in about a week and a half or so. So make sure you fill out those abstracts, get those submitted, and be part of the meeting. I think it's going to be a phenomenal meeting in a really exciting venue, and I'm really looking forward to being there. So that's the first thing. Second thing is, as we look at other stuff going on in Azure, it's really important to know that Azure is doing a lot of stuff throughout the year between the meetings. One of the things is these hot topics. These are geared towards residents and fellows, but it can be useful for anybody, and they're free to join. So please go sign up for these hot topics. The one coming up is on January 4th, approaches to neuromodulation. These are really small group kind of Zoom sessions you can do anywhere, anytime, and participate in this conversation. I think these are going to be great. We have ones going on throughout the year, so it's important to keep up and go to the Azure.com website and find these events coming up and save those dates. The other big event is the POCUS course in Chicago. Now, this POCUS course has been incredibly popular. It's been selling out every time. We're doing it once a year, and we have POCUS courses at the annual meetings as well. So look for the website, go to the point of care ultrasound course selection, and register for those because they do sign up very quickly. The next one's April 30th. Second thing I want to point out is Azure has launched a new website within its website. It's called Azure Pain Medicine Best. And what this is an effort that several of us have been talking about. How do we put the best video tutorials in one place for people to find? Now, whether it's med students, residents, fellows, or even people who haven't done these procedures in a long time, there's a lot of good content out there, and Azure Pain Medicine doesn't need to reinvent the wheel for every one of them. What we want to do is bring our community together in one place and give them credit for the work that they've created. So here we've started this process. We've got 3 current collections. So one on adductor canal blocks, and you'll see that there's videos that maybe you don't normally encounter, and people that are producing videos that you may not routinely see. And we're trying to bring those into one place. These are reviewed by a team of people within the Azure Pain Medicine website committee, and they're reviewed for quality on a variety of metrics, and the composite score is what determines whether they make it onto this website or not. And so we have adductor canal block, we have supraclavicular block, and we have erector spini plane block. And that doesn't mean that we're going to stick to 4. We're going to keep adding content onto this website. So if you are making videos, even just one video, you don't have to make the whole collection. We want you to submit it on here, and it'll get evaluated and possibly put on this website where everybody can watch. I encourage everybody to tell their trainees and fellows about this website, bookmark it, and that should be your starting point to looking at great content. Okay, let's move on to our topic for today. I want to introduce, let me bring him up here before I bring the article up. I want to introduce Dr. Mark Newman. He is the Horatio C. Wood Associate Professor of Anesthesiology and Critical Care and an Associate Professor of Medicine in Geriatrics at the Perelman School of Medicine at the University of Pennsylvania. Mark, that's a lot of titles. You're a busy man. Welcome.
Thanks, Raj. It's great to be here.
Yeah, I'm so excited to talk to you. I think we have a really interesting topic today, and one I think that's influential in our field of anesthesiology. And I do want to do a couple of disclosures at the beginning of this conversation. One is I am a member of the Azure Pain Medicine Board of Directors, which had nothing to do with this paper that we're going to be discussing. And our site at Vanderbilt was a recruitment site for this. It's one of the multiple centers involved in recruiting patients for the site, but I am not a co-author on this paper that we're going to be discussing. I hope that gets my appropriate disclosures before we have the conversation. Let me do the introduction of the paper here. So let me pop it up on the screen. So this was published in the New England Journal of Medicine, and I think that's a big deal. And I think that's one of the reasons we're talking about it, is that it's garnered a lot of attention for an anesthesiology publication to be published in the New England Journal of Medicine recently in November. So this is fresh off the presses, and the title is "Spinal Anesthesia or General Anesthesia for Hip Surgery in Older Patients." And this is targeted towards hip fracture patients that are coming in for surgery and are randomized to get general anesthesia or spinal anesthesia. So that's my lead in, Mark. Do you want to describe a little bit about the study, how you guys designed it, and some of the key findings, and then we'll go into some more detail.
Yeah, thanks so much, Raj. I think it's best to describe our paper by first kind of stepping back and talking a little bit about where we were in terms of evidence around this particular clinical question when we started this project. First of all, hip fracture is a hugely common issue in the United States and around the world. More than 250,000 patients each year break their hips, and their outcomes can be very severe. The rates of mortality and new losses of independence are high after hip fracture. It's a real public health problem, and something that anesthesiologists play an important role in, because we take care of these patients in the operating room. When we got started on this project in 2015, there were very few recent randomized trials that had compared spinal versus general anesthesia. There were some trials in the 1980s that had done this, and a few small trials after then. But most of what we had to rely on was retrospective, non-randomized studies. Those studies can be very problematic. They can be potentially misleading, because there's no way to tell whether or not the outcomes you might see in terms of a difference, spinal versus general, have to do with the anesthesia itself versus the characteristics of the patients. You can use statistical methods to try and adjust away those differences, but you can never totally be sure that you're doing all that you need to do to handle that kind of selection bias and confounding. Right. The absolute best way to get that handled is to randomly assign patients to treatments. And that's why randomized trials are so important. The other thing is, we didn't know a lot about the outcomes that mattered to patients. When we talk to patients who've had hip fractures, what they tell us is what's most important to them is getting back to functioning, getting back to independence, and most importantly, getting back to walking. We had almost no information at the time about whether or not the care we were delivering was impacting those outcomes. So that's why we wanted to do REGAIN. What we did is we randomly assigned 1,600 patients to get spinal anesthesia or general anesthesia. And we did this across 46 hospitals in the United States and in Canada. We used very flexible treatment protocols so that our study could be done across all these different places at all the different times that patients would come to the hospital for their hip fracture treatment. We measured a primary outcome of being able to walk, get back to independence at 60 days. And we did that in a blinded, very rigorous fashion. We ended up finding that there was no difference in the rate of return to independence at 60 days in terms of walking, or the rate of death at 60 days. We also looked at delirium, which was the same rates in each group. And we also looked at things like hospital length of stay, which we found to be similar across groups.
Let's break down a couple of those things that you talked about. I want to talk a little bit about the study design. So, a randomized controlled trial is not a randomized controlled trial, is not the same all the way across. So let's break down the words in your trial that are, so it's described as a pragmatic randomized superiority trial. Okay. Right. So the randomized part is easy. You guys on admission or enrollment, there was a process of randomizing to spinal or general anesthesia, and that was the only intervention that they were randomized to, correct? There was no other sort of prescription about how the spinal is done, how the general was done, and that kind of goes towards that word pragmatic. Can you help me distinguish that part, the randomization and versus the word pragmatic?
Yeah, it's an important question. When we do randomized trials, there are a lot of choices to make in how we design the trial. The classical kind of drug trial is something that we call an explanatory randomized trial. What that's designed to do is to look at whether or not a treatment works under the best case scenario conditions. In other words, when used as directed. The other view of trials is to talk about pragmatic trials. And those are trials that aim to understand how treatments work when they're deployed as they're used in real world conditions. In our case, we wanted to study whether spinal anesthesia versus general anesthesia might make a difference in outcomes as they're used in current practice. There could be a different trial that could take an explanatory perspective on this and, for example, could compare the best case scenario of spinal anesthesia versus the best case scenario of general. In other words, the most highly trained, highly experienced practitioner operating under very, very strict conditions versus spinal versus general anesthesia as they might be used in practice. These two kinds of trials give different kinds of information that are both complementary and important. What we wanted to do, though, was speak to what practitioners were doing in their daily work. And that's why we took a pragmatic approach. But
to
most
me,
most importantly, go ahead.
Well, I just want to clarify one thing in my understanding. I'm going to play the sort of ignorant person here, is that with pragmatic, there's the opportunity for more generalizability, but with the less detail in what you're getting out of it, as far as like you do this exactly this way and then you get that benefit, but it's more broad strokes. But with the explanatory trials, you get all the little tiny details, but it may not apply to your specific case, and then generalizability becomes a problem. So there seems to be two opposing forces between the study design and the impact of how people put it into practice.
It's exactly right. And that's one of the big reasons we wanted to do a pragmatic trial in this case. It would be a different story if we were introducing a new treatment, right, that had never been done before and that we wanted to see if it might work. But the reality is both spinal and general anesthesia have each been around for more than 100 years. People are out there using these in practice. In theory, we could have done a trial where we just did it at one hospital and we gave it just to our best folks, and spinal was done a very specific way. We could have that result, and I could say, well, at Penn, when we did this hypothetical trial, we found a result. But there'd be no telling if that might generalize to any other hospitals or even just the average hospital, right? When we do a pragmatic trial, and again, here we worked at hospitals that were big academic centers, private practice places. We had 7 great hospitals in Canada. We had a large spectrum of hospitals. So we're fairly confident that the type of care we're showing and we're comparing here is actually pretty close to what is real care.
Yeah, I do a lot of work with our group at Vanderbilt about ERAS protocols and implementing those and trying to show differences. And you realize that even within our own institution, ERAS protocols are implemented very differently. And so you can't generalize. The more detailed you get with a protocol, you can't generalize between colorectal and spine. And, so it's the same kind of thing where the more, again, I use the word proscriptive. The more proscriptive you get, the less generalizable you get. And it's a choice. It's not to say that one is better than the other. It's a choice between the two.
Yeah, and I think that what we've seen in the past with trials is there have been a number of important examples where trials that have shown big effects when they're conducted in single centers or just a few centers don't replicate when they get out to the world. At times, there can be harms that come from treatments that we fail to see when we're looking at them in these very tightly controlled settings. These are issues that we've known about in trials for a while, and that's why pragmatic trials are becoming more and more what we're pushing towards in clinical practice, because we want to be able to speak to what is the actual care that's happening and what are the real choices patients are facing.
Yeah, we were discussing this weekend when we were prepping for this, the 2001 Vandenberg study on tight glucose control. That's been a sort of a moniker case of tight study design versus generalizability and the negative outcomes of hypoglycemia that occurred after everybody sort of got revved up on tight glucose control after that study. Let me move on to the next part of this discussion, which I thought was something that I think we always struggle with. I always talk to my residents and fellows about when they're working on research studies, but even when they're reading research studies, is you have to go to the power analysis. You have to understand what decisions the authors made at the beginning of the process to design their study, what assumptions did they make, and how do they calculate their sample size. This is particularly important when you don't see a difference, and again, not that that's a good or bad conclusion. It's just the conclusions in context of the assumptions made at the beginning. Talk a little bit about your sample size calculation and your power analysis.
Yeah, well, when we started Regain, we planned for a sample size of 1,600 patients. We worked really hard to get all the way there, and we were proud that we were able to. That estimate of 1,600 patients was based on us hoping to be able to detect. We estimated that we'd be able to detect 80%, have 80% power to detect a relative risk of 0.78 for the primary outcome across groups at a significance level of 0.05. A big part of that assumption was that we thought that we'd have a primary outcome event rate of about 34% in the general anesthesia group. And we also had some assumptions around loss to follow-up and the amount of crossover we'd have across groups. As we explain in the paper, and as we show in the paper, our mean outcome rate was lower than we anticipated, and that likely decreased our study power to some degree. That said, we believe there's still a lot that one can learn by looking at our findings in terms of the numbers we present, in terms of what we were able to achieve in the study.
You explained something to me this weekend about how little difference you observed in your two groups. And as you sort of, you can't do this retroactively, but as you do a thought experiment of how many more people you would have to see and how big a difference there would have to be in each of those added sample size to start seeing a meaningful difference. Explain that a little bit better, because I don't think I'm verbalizing this as well as you did.
No, there are different ways of looking at trials, and it's a good question. And this is one thing that we'll be working on in our group over the coming months. There's a whole school of thought around looking at trials through what we call a Bayesian framework, where you have a certain prior belief or a prior expectation of whether there might be a difference in outcomes with one treatment versus another. And then you consider the information you get from the trial as new information to update that prior, right? To add to the knowledge you already have or the belief you may already have. When you look at trials that way, you can look at the data as they are, what we actually accomplished, and make an assessment about whether or not this changes your mind or if you need to still gather more information. And there are formal ways of doing that, and we'll be doing that over time. But even in an informal sense, you can look at our results and see that 18% of patients in the general anesthesia group met our primary outcome, and 18.5% in the spinal anesthesia group met our primary outcome. That was 132 patients in the general anesthesia group and 132 in spinal, actually. The delirium rates were also almost exactly the same, 20.5% in spinal and 19.7% in general. And again, these were fairly common events. We had more than 130 cases of delirium in the spinal and 124 cases of delirium in general. When you look at those numbers, that's useful information to update your prior beliefs, right? It would probably be a misstatement to completely dismiss this as not useful information simply because the rates were below the rates we had anticipated going in. Of course, we can't guarantee that we're ruling out a possible effect. It's entirely possible that if we kept the trial running, we may have ended up finding something different. But that said, with the information we have here, looking at what's on the page, there's a lot of useful insight that I think is important for clinicians to take to heart and consider how they might update their prior beliefs or assumptions.
Yeah, we're going to circle back to that at the end of the conversation because I think that's an important part of this conversation. One of the other things that when I was reading the article, my instincts, and I'm going to express my own bias here, is like, oh no, I'm much better than these people. Like my patients do so much better. Did you guys see a lot of differences in anesthesia care patterns across institutions? Were you able to have visibility about that or not, where you could tell if people were doing things in widely different ways? And one question that I'll tag on to this is there like huge swings in how people sedate patients during spinals? One group may give just a little bit of propofol, and one group may do like Versed, ketamine, heavy propofol infusions, and all this kind of stuff. I mean, do you see those wide swings?
Well, let me start from the outcomes and work backwards for you to answer your question. In the paper, we actually have an appendix where we show the rates of our primary outcome by site, and they're pretty much consistent across sites. We had a big variability in the numbers of patients by site, so we couldn't do a lot of refined analysis. Yeah. One thing we tried to do to control for these potential site variations was to randomize patients within site. So our actual randomization was originally stratified by site, which meant that each site would have gotten the same number of spinal and general cases. That, in theory, should take care of site level differences as you're describing. What ended up happening is we had too few patients in many of our sites to allow us to handle that in the analysis. But our appendix does show that it looks like the outcomes were pretty much the same across sites. So whatever the variability in care might have been, it looked like the end result was pretty consistent, at least for our primary outcome. What I'll say about variability in things like sedation regimens is when we look at the average type of sedation that people who had spinal anesthesia got, it was pretty consistent with what you'd expect to represent typical care in the United States. The mean dose of midazolam was 2 milligrams, which is a pretty standard amount of midazolam to give for preoperative sedation. And the mean rate of propofol infusion was in the range of 30 to 35 mics per kilo per minute, which is, what we will typically run in a case like this. For some patients, that's higher than we'd want. For some patients, it might be lower, but that's not out of the range of what we'd expect is normal. Of course, there's some variance around that. But again, many of our sites had fairly small numbers, so it's hard to make big conclusions about which sites were doing, a better job or a worse job in terms of sedation.
Now, there were a couple of things that seemed to be different between the two groups in your study. They were more shorter-term outcomes like death during hospitalization, acute kidney injury, and post-op ICU admissions. Now, these are smaller in the sense that they weren't what you detected as important to patients, where you talked about mobility and return to normal function. Obviously, death at 60 days is important. But when we look at some of the retrospective studies that have looked at differences, the differences are looking at some of these shorter term outcomes. So are these shorter term benefits for some people maybe enough to justify spinal over general when, even though the longer term outcome may not be impacted by that choice?
It's a great question, and it's a really important question. I think the answer to it is that it has to be interpreted in context. One thing that's important to remember is that our study presents averages. Any trial is going to give you average results, right? And we all know that there's no patient who is perfectly average, right? So all of this work needs to be interpreted in the context of individual patient needs. Those needs include their medical needs, but also their preferences, right? We, as anesthesiologists, are always working to tailor our care, right? So for patients who may have specific medical conditions, physiologic states that might lead to one or another type of outcome, for example, if you have somebody who's got an active pneumonia but still needs to get their hip fracture fixed and they're on oxygen, that might be somebody where you say, well, we're going to consider what we saw in REGAIN. We're going to see what's in front of us and make a decision based on what we think is right for this patient's physiology. I think for a patient who looks more like the average patient, looks like the patient that we saw in our trial, I would say that balancing what we think might be some potential short-term outcome differences, which again, we can't say really much definitively about because these were purely exploratory outcomes. They were
Right.
very low rates overall, versus the end outcomes, which we talked about in terms of 60-day recovery, 60-day walking, and length of stay, and location of discharge, all of which were pretty similar across groups. These are things that I think we need to integrate with our patients. And I think we need to talk to our patients about what the trade-offs might be. So I would say that it's hard to make a blanket statement that spinal anesthesia or general anesthesia might be preferable for everybody or under any condition. But I would say that what our study does is it gives a lot more information than we ever had before to have informed discussions with our patients about what they want and what might be right for them.
Yeah, I think that personalized choice, one of the things that I read when I read this article is, one, it gives me a little bit more confidence that when I do have to choose general anesthesia or want to choose it or end up choosing it for a variety of other reasons, I don't have to feel that guilt that I'm doing something less good for my patients. There may be some short-term impacts that I have to deal with, but overall, their outcomes, the things that we worry about the most, are they going to die after a hip fracture, which is a big worry? Are they going to be able to return to their home and function by themselves, which is a big worry for us and for them, obviously. We talk about things like pain control. We talk about things like acute kidney injury, but if it's not impacting their overall outcomes, it gives me a little bit more confidence when I have to make that decision that we can make those decisions based on other things, other variables. Does, the patient have extreme scoliosis, and a spinal is going to be much more difficult and potentially harmful to a patient and painful to a patient? Well, I might say, okay, it's not worth poking their back for this. I'm going to do a general anesthesia and feel confident that I'm not really choosing something bad for the patient in that moment. That's how I kind of look at this and say, okay, it gives me confidence to have more flexibility in the discussion with my patients about what's possible for them.
I agree. I think that incorporating what patients want too is also really critical, right? And that, as you mentioned, you said, you might not feel so bad. I don't think we should be making patients feel bad for having preferences and choices.
Yeah.
I think we often underestimate what patients can accommodate in terms of integrating this type of information and participating in decisions. There are definitely some scenarios where patients prefer not to be involved or may not be able to be involved. But what we learned from Regain in going through the consent process with many patients and families is that many of them had a lot of questions about their anesthesia care. Many of them wanted to learn more and wanted to think through these choices. What our study does is it gives folks real information that they can use to have conversations about what the trade-offs might be, not just in terms of binary better or worse kinds of things,
Right.
but in terms of actual numbers, right?
Yeah. What do you think? We talked a little bit about some of the limitations that you guys encountered in designing the study and executing the study. What do you think that something that we haven't mentioned? Are there any other concerns? Not concerns, that's not the right word. Limitations that came out, and you guys described a lot of them in your paper, that are important when people are interpreting the results of this paper and how to implement it in their practice?
I think one thing that we worked very hard to do was to enroll a very generalizable sample of patients into our study. We had very broad inclusion and exclusion criteria. We allowed people to be in the study even if they couldn't give their own consent, and we had to go get consent from a proxy family member. We didn't restrict people based on, whether they had delirium or not. We were able to include people who had delirium often. So we worked very hard for that. That said, there were many patients who declined participation or who ended up being selected out because of medical risks. And even beyond the inclusion-exclusion criteria we had. I think that's always a challenge in trials, to enroll a broadly generalizable sample. We tried very hard to do it. I think we largely succeeded, but that's an area where I think we can always sort of try to do better. Part of that is in designing the trial and trying to run it well, but another big part of it is in working to build trust with our patient communities. We had a lot of patients refuse to be in the trial simply because they didn't feel comfortable being in medical research. distrust
Right.
of medical research is a real thing, and it's a real problem. And it's something that I think is on us to work to try and remedy over time.
Where do you go next with this? I know we had some conversations that there's other institutions, other groups that are repeating similar kinds of concepts in hip fracture patients at institutions across the globe, and some of that data is going to be just out or coming out soon. Where do you think there's a gap that you want to explore in this area still?
Well, I can tell you some of the things that we're doing and some of the things that we see on the horizon. Within the Regain group, we have other papers coming out. We did study pain experience, satisfaction, and analgesic use, and we'll be working on those results over time. We also have long-term outcomes that go out to a year. We'll be working on those as well. And we'll be doing some more statistical reanalyses of our data, such as the Bayesian reanalysis I mentioned earlier, to get a sense of different ways of looking at our results and how they might be used for clinical decision-making. There are two other major trials that I know about. One is called the RAGA trial, and it was published yesterday in JAMA, looking at anesthesia, spinal or regional versus general for hip fracture outcomes. One unique thing about that trial is the folks in the regional side didn't get any sedation. So those are interesting results that I encourage people to look at and make their own minds up about. And there's a big trial that's happening right now in a German network. It's called iHope. It's led by a colleague of ours named Mark Coburn at the University of Bonn. It's about 1,000 patients, and it uses a very similar approach to what we did in Regain. But that one's focusing mostly on postoperative complications. So that'll give more definitive evidence about those short-term questions that we were talking about earlier. So over the next few years, we're going to see a lot of new information coming out about neuraxial versus general for hip fracture. I think there are big questions still unanswered that we could talk about. We could talk about looking more at some of these higher risk subgroups, such as people with pulmonary disease or cardiac disease in hip fracture. And also, I think there's a big opportunity to study more closely these choices in non-hip fracture contexts. Our study is the largest ever randomized trial comparing neuraxial anesthesia to general anesthesia for any surgery in adults. That means there are opportunities to study neuraxial versus general for elective joint replacement, where we have a lot of retrospective studies, but then not that many great prospective randomized studies. I think that's a huge opportunity for the regional anesthesia community to help patients by giving them better information to guide choices.
Yeah, and I want to commend you guys for doing that hard work. As we discussed prior to this show, you've been working on this for over almost 10 years in some form or fashion to make this happen. These are not easy things to do. They're often, that's why there's so few of these, and no study is absolutely perfect. There's a lot of, for all our trainees out there, when you're interpreting and reading journal articles, you have to know what the assumptions were at the beginning to figure out how to interpret it for your own practice. And I think that's an important part of any kind of analysis of the research. But this builds upon prior knowledge, and it leads to more questions, which is always part of the scientific process. So I commend you guys and your whole group for carrying through. I got to see some of it on our end at Vanderbilt and how hard it was to recruit these patients. This was no small task, and a lot of people did a lot of tremendous effort to make that happen. Mark, I really appreciate this conversation. I think that this is important. We need to be talking about this stuff. I'm a firm believer that we should always be reevaluating our practice and how we do what we do, and then we improve from there. That's the only way we get better. And if we're not critical of our own selves and our own choices, then we're not open to improving ourselves as well. So this is, I think, a really important article in that conversation. Thank you very much. It was great chatting with you, and I look forward to seeing all the other work coming out of your group because I know there's more on the horizon.
Thanks so much. And I want to say thank you for this opportunity. It's an honor. Thank you to Vanderbilt for the way they helped. And I want to thank Azera. Azera's given me the chance to speak at their meetings in the past, to participate in this podcast. The regional anesthesia community, I know, is a community that's very, very committed to patient care and doing the right things by patients. And we felt very supported by that community all the way through. So it's a real pleasure for me to be able to speak to you in this forum and really say thank you to all the people in the Azure community that helped us get this done. We had more than 350 collaborators that we name at the end of the Regain paper, and many of those people are Azure members, and even more probably benefited from Azure's work. So thanks again for the opportunity, and please keep in touch.
Absolutely. Good talking with you, Mark. Thank you, everybody.
Thanks.